This is Jonathan Wick, Vice President of Health Insights at FinThrive, and I want to talk to you about 20 reasons to rethink revenue management. 20 reasons to rethink revenue management's a function of a booklet that was published that you're welcome to have after this recording. Just reach out and we'll have a link that you could connect to, and I'll send one to you, or we'll get one to you somehow, and you could look at these reasons in more detail. The first reasons to rethink revenue management really surrounds waste. And if you've worked in healthcare, especially on the finance side, you'll understand that there's a significant amount of administrative waste in the tune of 935 billion with a B dollars. As we're looking at administrative waste and the things that are causing that, they really surround the patient account lifecycle. I would argue some studies by JAMA and Humana have also looked at overcare or overutilization or failed care. There's a lot of fraud and abuse from the Medicare fraud and abuse work that's been done. A lot, though, I think the majority or lion's share is coming from administrative waste in the forms of prior authorizations, denials, pre-certifications, downgrades, resubmitted claims, disparate systems not talking to each other, and copy and paste fatigue, I like to call it. All those things cause a lot of wasteful spend on the administrative side. It's not going to get any easier, too. This is a quote from my second book, and there is a lot of payment uncertainty right now. There's a lot of friction, and I would argue patients are the new payer, and they absolutely rely on a good experience, both clinically and financially. And for you to excel as an organization, you really need to have really good, collaborative, elegant, and I would argue technologically enabled processes to ensure you're maximizing your experience and reimbursement with both patients and payer. Visit volumes are something that has been very volatile over the last 4 years, as we're looking at how COVID impacted there on the left side of this graph, and how we're seeing basically a new normal in volumes. This banding is below the surface. That 0% line there is normal volumes, and we've seen, especially in the area of the emergency department, double-digit deficits in terms of patients not coming back, and that translates, of course, to inpatient. Outpatient, I think, is something that's slowly transitioning to the ambulatory area or freestanding. But my point is that you're seeing patients make choices in places that maybe aren't the acute hospital. There's patterns here, too. It's very apparent in the outpatient side. When there's a holiday, people aren't going to the hospital. That's Thanksgiving and Christmas there the last 3 years. And you could see those other kind of troughs that are happening off cycle really don't have a lot of seasonality to them. And I think it's a function of people going to other places and understanding what they can do in the market. Inpatient has outpaced ED in recoveries, but we really have seen this tight banding of volumes into 23 and 24. The government is the number 4 reason why you should rethink revenue management. There are some key policy rules in the RCM market. These are the big 3, I call them. Price transparency, which really isn't new, but it came out in 2021. Surprise medical billing, or the No Surprises Act, came out in 2022. And then payer price transparency, or the transparency in coverage, or TIC rule, came out about 2 years ago, but it's being phased this year as well. These are huge rules, gang, that have gone through different various levels of I guess I would say adoption and enforcement. And we're seeing price transparency probably be the most mature, if you will. There's about 17 hospitals now that have been posted on the CMS website for violating the fairly simplistic rules of price transparency and posting your charge master, a machine readable file with negotiated rates, those types of things. No Surprises Act, I would argue, is in its infancy. You're starting to see some monitoring, not much enforcement yet, mainly surrounding the good faith estimate, those types of things. And then payer price transparency is relatively new. They're basically following suit on the price transparency rule from 3 years ago, but they're having to also post their reimbursement rates at the payer level, and they have different enforcement arms as well. Number 5 is profit margins are elusive. I'm a big fan of Kaufman Hall. This is their report from February. If you were to take March and April of 24. Those numbers are very similar in the 3 to 4% range. So we're starting to see kind of this propeller pattern of recovery happen. I'd say most hospitals have broke even for the most part. The deficit is certainly becoming more and more positive. 2022 represented one of the more difficult years healthcare has probably ever faced, mainly because of a three-headed monster, I like to call it, of labor, patient volumes, as I mentioned, and then finally payer relations. And the labor element was very pronounced in the clinical areas, but we also saw that in some of revenue cycle. And just having people there to actually deliver care or submit bills was a huge issue, and the cost and the premium expense in either onboarding or the turnover cost was significant. And then payer relations really comes in the function of denials, which we'll talk about here as well. These are some graphs that you certainly could review at a later time or in the booklet, but they talk about, especially in those green bars, the cost comparison from 21 to 24 in terms of labor and supplies and basically volumes and things, and how there's been these deficits that have occurred over time, or having to pay premium dollars, and that certainly doesn't allow for growth and profitability when your expenses are outpacing your revenues. There's variability in this report as well, and I think it's a function of something Kevin Holler likes to talk about from Fitch, a trifurcation. Those hospitals that are on a path in the middle are probably going to stay there. Those ones that were growing before COVID happened, or before some of these things, that had a good days cash on hand position, good investments, and some resilience, I would argue, in their finances, will tend to grow at a much faster rate than those that maybe were fragile in rural areas or single soul community hospitals. But the range in this is significant. About 40% of hospitals, a little less than half, have some financial performance issues that range in the 4 to 19% range on the negative side. And as I mentioned, there's some that have substantially recovered financially on the positive side, and they've had higher outpatient revenues, reductions swiftly to contract labor, and they've became more efficient as hospitals. One thing I think I see from those that are on the positive side is that they have invested in technology. They are consolidating the RCM footprint. We'll talk about that here in a minute as well. Payer mix is the sixth reason to rethink revenue management. You're seeing the commercial market shrink here. That's that lightest green or lighter green there in that third bank over there, from 33% down to 22.3%. We should see that next year. Another way of looking at that is 1 in 4 of your patients are going to have private insurance. It's a pretty small number if you've been in the industry for a while. And about 1 in 2 or half of your patients will probably be funded by Medicare, Medicaid, or Medicare Advantage. And then you've got, the other quarter, which is really self-pay or health benefit exchange plans or others as you proceed. The seventh reason to rethink revenue management really surrounds the employer. They occupy about 70% of the healthcare premium these days, and you could see that across different types of plans. And I don't think they signed up for this. And if you research it, you'll start to see employers take more of a pivotal or forefront role in healthcare. It's their second expense besides labor as an operating entity. And they really want to understand how they can keep healthy employees, but not have this large burden of $20,000 to $40,000 per employee at their organization. And they're trying to have employees be more engaged in costs and utilization. And I would argue that's going to come in the function of less choice. It'll probably come in narrower networks. It may come in higher deductibles for services that maybe have high cost, high utilization, and those types of things, as they try to kind of burn the candle from both ends to narrow that variability and cost down, so that they could project and grow as a business without having to be anchored or moored by healthcare costs of their employees. Premiums are rising. Most Americans spend more on their healthcare premiums, $22,500, than they do on their mortgage. I think that's important to understand. All the time you've spent in your mortgage and others, you probably spent less than an hour picking your healthcare coverage maybe. That's the eighth reason why you should rethink revenue management. It's a very large investment on the consumer level. And what do those benefit plans look like? What's the cost sharing look like? What's the network look like? How frictionless is that? What's it look like for the market? About 43% of workers are underinsured. It's a term you don't hear about that often, but that really is a high deductible or catastrophic plan where there's this, I guess, false pretense that there's coverage, but in fact, they have a gap and they may have a $5,000 or $6,000, deductible. Most Americans, they're about 40% of them have $400 in the bank. That's not much dollars of liquid income. If you've engaged in the healthcare system, that's going to take less than probably one claim for you to hit that. And then all of a sudden you're borrowing or delaying or deferring those payments over time. The ninth reason is the government. Uncle Sam will certainly play a larger role in the payer mix as well. And the private insurance market, Medicare Advantage, is there also. So as you're seeing Medicaid, Medicare, and then ultimately Medicare Advantage being managed by the private insurance companies, they have surpassed that mark. There are more Medicare Advantage enrollees than Medicare these days, and it's important to understand from at least when I've talked to hospitals in the market, MA plans are very, very difficult to negotiate with if you have any at all, and they're very, very difficult to get payment from. High levels of denials, much higher than traditional Medicare. Lots of variable rules depending on the payer that's managing them. A lot of, I would argue, beneficiary confusion, understanding where they can go and what their costs are. And there's been a lot of governmental attention to these MA plans as well in terms of making sure that they're on par and not being more restrictive than traditional Medicare. The 10th reason really is hybrid work. And I think we're kind of in that new wave now where most organizations that I talk to have at least some combination. Some are 100% hybrid, some maybe half. They may be having folks. I've seen some actually start to bring folks back. As that makes sense. And there's challenges in that. If you've created it, it's kind of, this has been birthed, right? You can't put the baby back in the womb. It's out there. It's a child that we have to bring up and rear into the world now as this hybrid work environment. So you may have lost the infrastructure or the actual plant space to have these folks, or you may be struggling to find a workforce to bring them back. But I think best practice is some hybrid model that looks at these four elements of technology, culture, performance, and people, and figuring that out. But if you try to go one way or the other, I think there's challenges on each side. The 11th reason for rethinking revenue management does surround that labor pool. This is the Bureau of Labor Statistics JOLTS, or Job Opening Labor Turnover Survey. And if you were to take the left side of this graph and shoot it, all the way around the room that you're in, it would look like that pretty much. You'd have an orange line there that's showing hires substantially lower than that of openings. And that makes sense, right? You're always going to have positions of a greater magnitude or more of them of being open or posted than those that you're able to fill. And that delta's been running, about 500,000 for years, for decades. COVID happened. You had a rapid increase of hires to kind of handle those floods and phases of stages that came through, those spikes and COVID outbreaks. And then, you've seen what I think is most concerning. These openings kind of come out and they've plateaued a little bit, but they've basically in that time almost doubled that delta, if that makes sense. And that's a really big deal. So even if you wanted to hire folks, I would argue that they've gotten out of the industry and don't want to come back. And revenue cycle is not an area that is, I would think, immune to that. This obviously is highly weighted on the clinical, specifically nursing side, but revenue cycle has had its share of folks. And in conversations I've talked to, leaders at organizations, they've said, we can get people, but we lose them almost as fast as we get them. The average hourly rate in communities is often on par with fast food or retail or groceries in town. Not that there's anything wrong with those industries, but these are typically highly skilled individuals that you need once you've gotten them trained up. And hospitals don't have a lot of capital or operational dollars to allocate $1, $2, $3 an hour to every associate. It's a highly labor intense area, and that's tough. And that's what results in freezing in open positions, I think. And when that stuff starts to happen, people leave, and it's a cycle. I haven't looked at this data into 24 yet, but I have a feeling it may get into the 1,500 or 1.5 million range there, and stay there for a while. So my point is not necessarily that the labor pool is volatile. It's that we've actually kind of stair-stepped up into this larger gap of the need versus availability of staff out there. And as I mentioned, that's not unique to the clinical area, and finance is experiencing it as well. And as you see that, you see revenue cycles start to have these reported things go from kind of bad to worse: billing errors, hold times, cancellations, operational deficiencies, price transparency compliance as well. The 12th reason to rethink revenue management really surrounds the saturation, if you will, of third-party RCM tools. My hospital, I had 26 different systems. In talking, we've done some surveys at FinThrive as well that can range anywhere between 10 to 40 different systems. There's several systems here in Colorado that I've talked to that have, dozens, 20 to 30 to 40 different things to kind of make bills go and get paid, if that makes sense, or make sure patients have a way to get into the system and kind of self-navigate their appointments and their payments and things like that. And what I find interesting on here is the adoption from year to year. This data comes from HBI and class, and it really is a function of understanding what things have worked, where the maturity levels are, and you look at things like charges and claims, and I would argue eligibility. Those ones are in the high 80s. You start getting into things like prior auth, and those have dropped down pretty significantly. Patient engagement has gone down a little bit. Propensity to pay, given the volatility in the market from the economies and things, have also gone down. Estimation has been kind of transitioning more and more to incumbent EHR technology as you move forward. So it's important to understand what your portfolio looks like, what things your EHR can and can't do, and where you do need to supplement that with best-in-class technology that allows for you to capture every last dollar and not leave revenue on the table because it's your money and you need to go get it. And EHRs were never really designed to kind of bird dog cash that got lost. They were designed to clinically document care and submit bills, but beyond that, they tend to struggle. Point solutions are certainly proliferating. That's the 13th reason. I call it vendor fest. There are just so many different vendors out there that make something to fix some part that has broken the system, and there's lots of opportunity for that. The issue with that there in the middle is that you get disparate results. About a little over 2/3 of hospitals use more than one vendor for revenue cycle. As I mentioned, that number is often in the dozens, but that leads to denial issues and a vendor cost footprint issue in terms of connections or VPNs or secured file transfer protocols. Those types of things are hard to maintain, and your relationship with your CIO and your IT department is important. But we've seen exposures from different companies out there with the event that happened to Change, and I think we recently saw other organizations also have at the clinical level happen, and it's exponentially getting there. So it's important to look at what your footprint looks like, not only from a financial performance, but is it secure? Do you have redundancy or resiliency in place? I don't think people were talking about secondary clearinghouses, before this year, and that's something to you certainly consider to make sure that your cash is flowing and that you've got some level. You've got redundancy with probably lots of other clinical systems, but financially, it's probably time to look at that as well. But do you ride this Franken cycle? The majority of hospitals have multiple vendors, as I mentioned, and this can cause issues from a cost standpoint. Many of them do the same things as others. The security and data risks I mentioned, they're siloed. They're not talking. You don't have kind of analytics and an end-to-end type of insight platform. There's not this platform effect that you can get by using a single vendor, and that really does result in dissatisfaction if folks are having to hop outside of their workflow to multiple screens, and really causes a lot of inefficiencies. As you look at your existing RCM processes, you see that revenue cycle, the 14th reason to rethink revenue management, really surrounds the existing processes aren't working. If they did, it would look a lot like this. You'd have all these encounters, all this information flowing through your revenue cycle pipe, and you get paid. But we all know that that's not the case, and you have these leaks that occur, and revenue cycle is there to make sure that every last dollar is captured, and that those denials, underpayments, reimbursement, the patient payments, the patient onboarding, the patient self-navigation, all the documentation, all the reimbursement from the federal government is happening at a level that needs to. And if it all worked well, there wouldn't be third-party softwares. I would argue there probably wouldn't be these multi-million-dollar expensive EHRs with all these different modules and things if bills could be submitted and paid based off their merit, and they were completed and documented in a fashion that the payer felt warranted reimbursement as well. Denials have quadrupled since 2018. This data comes from Clarivate and Health Business Insights. And those of you that have been in the market long enough, you probably understand that the baseline rate has been, about 1% of NPR, and just seeing that, skyrocket has been somewhat troubling. I haven't pulled 2024 data, but will and look at that as we proceed. And I have a feeling it's going to stay up there for a while. And I've got theories. We just don't have time on this call to talk through why that is, but there are certainly theories out there as to why denials have gotten worse and how they're going to stay there. And they are all payer driven. I've seen many kind of math problems where it says payer equals denials, and there's not a lot of love between provider and payer right now, and there's a lot of pain. And these are write-offs too, gangs. This is not initial denial rate. This is actually what's lost. These are fatal write-off adjustments, and so this is troubling. It'd be interesting. I'll be happy to hear from you. Please reach out if you're watching this on demand, and let me know what your rates are and if you've gotten better or worse, and if you're making this go down or up. What I've instructed hospitals when I'm consulting with them is really, it's not so much the number, it's the direction. And you want to, it's like a flood. You kind of want to put the sandbags up and start re-diverting that water and start to get that level to come back down. I don't know that you're ever going to prevent them. It's a game of whack-a-mole. You're always going to have write-offs in some magnitude. It's a cost of doing business, unfortunately, but you want to make sure that you're decreasing in altitude or at least staying at the same altitude at your organization. If you're not, please get in touch with me and let's try to figure out some strategies to work. Underpayments are another element of this reason, and MGMA did this wonderful study a few years ago saying that on average, organizations have about 7 to 11% of their claim inventory denying. That equates to about $27 million with an M dollars for a mid-sized system that payers just frankly aren't paying. And they do not pick up the phone and call you. They never did with me and say, hey, Mr. Wick, we shorted you last month. It'll be on your next check. It just doesn't happen. It's something where the burden of proof lives with the provider and they have to share that with the insurance company. It breaks out in denials and underpayments, as I mentioned, and that's about 9% of revenue, that 27 million there, as you mentioned, right in that 7 to 11% range for denials or underpayments, and the denials, if you start adding those up, that's where that number comes from. And prior auths certainly are the bane. I think everybody's looking for a solution. FinThrive's working on a solution. Should have one this year, and we're excited about that. And with that, a denial prevention platform that allows you to manage those claims in a way that's effective. And underpayments, certainly important to understand your contract management, claim strategy. A platform provides some insights there that are longitudinal in nature, I like to say, to where you can understand how the eligibility response is related to your charge master, that's related to your contract, that's related to your claim, and ultimately your cash. And having all of those elements within one system really allows you to understand where you can effectuate change that drives revenue. Underpayments are in the 100 billion with a B range per the American Hospital Association. That's a report that comes out, and it's not going to get any better. I think Medicare and Medicaid run 70 to 80 cents on the dollar at best on the Medicare side, and on Medicaid it's maybe 30 to 40 cents on the dollar. And the unwinding certainly has put a lot of folks in the self-pay bad debt bucket, or maybe they've moved over to the health benefit exchange or over as a dependent on another privately held commercial plan. Nonetheless, as you saw early here, Medicare and Medicaid represent most hospitals, at least half of the payer mix, or somewhere north or south of that. But it's the majority payer these days when you combine governments or government payers, and it's not a lot of negotiation on price, and a lot of regulation in terms of making sure things are documented and being paid appropriately. So a lot of administrative burden comes from these plans as well. Because of that, you're seeing commercial rates have to supplement these governmental underpays. And there's a lot of variability here in all hospital services. There's a 259% cap out per this study from Kaiser Family Foundation above Medicare. On an average of 199%. The low end, it's at least 141% of Medicare. You look at inpatient, it's 222 and 151 with an average of 189. Outpatient, large variability, almost 400%, 358%, 264% is the average. 2.6 times, gang, what Medicare pays is what most hospitals get on outpatient. And then physician services, probably one of the tightest bands for good reason. They're charge masters, and they're fee schedules are certainly limited to compare to the others. But important to understand in this slide that, as you're looking at your reimbursements, what is your opportunity? You don't have a lot of negotiating power as you move forward, and we'll look at that as we go. 15th reason, value-based care is not a silver bullet. This is a CLAN survey. I can certainly get you the source if you need it, but they track very closely traditional fee-for-service all the way up to full-blown population health management, PHM, and then everything in between, from fee-for-service pay-for-performance contracts with links to quality to alternative payment models, and ACOs and those. And the point of this is they're still a minority in contracts. That orange bar there on the right, 41% of all contracts are still fee-for-service, and about 60% are across those other categories. And this was 2022 data. They have not gotten that much better. And I think that's just the model's just not set up to reimburse on a value-based world. I think everyone's agreed that that's the path that we need to get there. Medicare is kind of the lead horse in that race, and putting rules out there that basically reimburse at that level. Commercial payers are starting to get there, but between member attrition and basically reimbursement models as they exist today in terms of covering the current utilization and cost packages, which we could certainly debate later, has caused a lot of headwinds for the value-based care market. Healthcare hasn't fixed itself is that 16th reason. We saw detriments in cash over 21 and 22. As we're looking 23, probably had a level year, if I had to guess, and certainly could look at that. This booklet talked through some of those, but most had about a 15% level in cash depletion from 21 to 22. And you can see S&P and Fitch over there on the right. The change event certainly probably dropped this down a few more days, if I had to guess, in February and March, and some parts of the country in April of 2024, just in terms of cash being stuck if they had tight exclusive arrangements with some payers. I've talked to hospitals that have less than 100 days cash on hand, like Doylestown there, and you start getting into that 40-50 range. That's when payroll and some of your other kind of liabilities start to come into play, and that gets very scary. And so days cash is something you're going to hear more and more about, and you're going to want to see growth in that area as we're moving at something the rating agencies look very close at too, in terms of understanding the fragility of an organization. They don't have a lot of negotiating power either to kind of fix that. On the expense side, labor and supplies are relatively fixed. You saw that in some of the earlier slides I showed you. And then on the payer mix, I've mentioned that between the government and the commercial side, that's most of the pie. And then you've got, government self-pay represents most of the pie. Commercial is only 25%. And you can't keep going back, I think, to these private payers and saying, I need more money. They've heard it, and it's also not going to effectuate a lot of your mix. So it's going to come down to other things: operating more efficiently, automating. I would argue holding accountable to the payments that you're getting today, and trying to effectuate that versus getting a higher rate, other than something that's closely aligned to CPI or consumer price index and those things, and inflation. But asking for rates above that, it's going to be extremely tenable and difficult over the next few years. And it's a very small part of your mix, I would argue, these years. The 17th reason to rethink revenue management really surrounds engaging patients, and these three tenets really resonate with me in terms of these conversations need to be transparent. There needs to not be any hidden information. I've heard from many organizations that they can't provide an estimate, or they're hesitant to, or they don't want to post their charge master because it's really difficult to pre-do this ahead of time. It is for some things, but not everything. And I think it's important to meet the patient as a payer. They are a consumer. Healthcare is one of the weird industries where nobody knows what things cost, and they can't effectuate that. And I would argue that you actually can, and you could probably do that on a large proportion of your business, and you probably could follow an 80-20 rule and get pretty damn close to being where you need it. It needs to be meaningful too. This is your coverage, these are your costs, these are your choices. What would you like to do? I don't think we're having a lot of collaborative conversations with patients as consumers these days. It's kind of dictated towards them. And then when it comes time for payment, how frictionless is it? Are you sending out electronic statements? Is there interaction there? Are you relying on a customer service center to answer those calls and questions, or are you, putting things out there that help educate your community and your patients about their bills? And are you providing tailored payment options for your population to where they understand what their bills are and how they can pay them over time? Consumerism is absolutely impacting healthcare. 80% of patients have researched their healthcare costs. I remember when that number was 30%. It's going up dramatically. Half of patients, gang, still don't understand their bill. I find that number very troubling. And I think that's just a function of how complex the system is. But really make the bill as understandable as when you go shopping in a store, at a Costco or a Sam's Club, or when you're shopping a vehicle. They all have a sticker there, and I think we can create more stickers, and try to make them as simple as we can, and understand that they are estimates and they are ranges, but folks need to understand those things and try to simplify them. And I applaud those organizations that have combined their professional and hospital and specialty billing into one statement, and have collaborated too with the payer in some cases, to kind of pre-adjudicate those things and have advanced EOBs, if you will. I think there's a lot of potential there. And then this is my favorite part. Patients want to pay you, the majority of 65%, but they are confused and somewhat scared, and I would argue uninformed about how and why these amounts are where they're at, and what mechanisms they could do to look at them and actually be part of that process. It's very, very important to ensure that patient financial experience is pivotal, sorry, and really a priority at your organization in terms of the tip of the spear, in terms of what's happening with your population. The patients are the new payer. I think there's a lot more power with patients than people are giving them credit to, and they're going to vote with their legs as they go. As we look at the other elements of care and where we're at, healthcare is behind digitally, as this graph has shown, and they have seen different levels, and healthcare is there in that bottom bank in terms of just usage and where they're at. This study comes from McKinsey. Collaboration is a huge point with healthcare right now as well. FinThrive is very proud to kind of get these 17 transactions put together, where you're playing tennis with a payer these days, where imagine a clearinghouse where this information was all in one and you're able to see it then. These workflows absolutely can be automated in revenue cycle. It's the 19th reason for rethinking revenue management. This is just a laundry list of bots from a robotic process automation standpoint that allow some savings that are pretty significant on the FTE and cost side, in terms of generating revenue across several use cases. And then finally, a platform. I've talked about that, but do you have this hub and spoke model at your organization of 20 to 30 software entities, or do you have a platform that allows you to manage those things longitudinally, where you have end-to-end analytics and develop insights across that longitudinal claim, and where you're supplementing the EMR in terms of what needs to happen from a management standpoint for your revenue, so you can truly rethink that. And this is what it can look like. This is what types of things can happen to drive revenue from bottom quartile performance to upper quartile performance. And you can see double-digit million-dollar impacts when you start leveraging people, process, and technology in a focused way that meets some of those tenets of rethinking revenue management across those 20 points that I mentioned earlier. Jonathan Wick, VP of Health Insights, happy to talk through more of these. Click on that QR code down there, zip me an email. I'll ship you a booklet as well. I hope you have a great rest of your day, and thanks for tuning in.